Welcome back to the Deep Dive. We're here to cut through the noise and give you the high-yield info you need, especially, for those tough postgraduate ortho exams. Today, we're tackling a really complex revision topic, hip fusion, and then the often tricky conversion back to a total hip replacement.
That's right, and this deep dive is really geared towards what you need for those vivas or short answer questions. It's based on the Ortho-Made Simple notes you can find over at mokyingren.sg. These were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, got his FRCS back in 2022. The idea isn't just listing facts, but getting the why behind the techniques.
Exactly. So our mission today, distill the absolute must-knows. Let's start right at the beginning. Hip fusion. What are the main technical options, the two basic routes?
Okay, fundamentally, we tend to split them based on whether the hardware actually crosses the joint itself. So first, you got the extra-articular technique. Think like a cobra plate, typically. The whole point there is that no screws actually go into the joint space you're fusing.
Okay, so that's one. What's the other way?
That would be the transarticular approach. And as the name suggests, here you're deliberately putting screws across the joint line, across where you want the fusion to happen, using the hardware itself for compression, really.
Right, and before any hardware goes in, you've got to prep the joint surfaces.
Yeah.
Classic exam question, this one. How do you actually denude the cartilage? Is it the same for the socket and the ball?
Ah, good point. No, it's not. You need different tools. And knowing that shows you understand the anatomy. For the acetabulum, the socket side, you really need to use a reamer. Gets you that nice, consistent surface down to bleeding bone.
Okay, a reamer for the acetabulum.
But for the femoral head, because of its shape, its contour, you'll typically use a burr that lets you properly get all the cartilage off that rounded surface. It's about using the right tool for the job.
Got it. Burr for the head, reamer for the socket. Now let's get to what feels like the most critical part, the position you leave the hip in. What's the target, and why is getting this exact position so important?
This is absolutely key. The exam answer and the functional answer is 20 to 25 degrees of flexion, neutral abduction, adduction, and neutral rotation.
20 to 25 flexion. Okay, why that specific amount of flexion?
It's mainly so the patient can sit down reasonably comfortably without throwing their lower back into massive lordosis or having their pelvis tilt like crazy. It's a functional compromise.
Makes sense. And the neutral for abduction, adduction, and rotation.
Yeah.
Why is sticking to neutral so critical there?
Well, if you fuse them in, say, significant adduction or maybe external rotation, you immediately put weird stresses on the knee. Then the ankle and the spine have to compensate. And that just speeds up the clock on all those adjacent joint problems we know are likely down the line.
Right. The downstream effect.
Exactly. Plus, and this is crucial thinking ahead, that neutral position is also the best for preserving whatever abductor muscle function is left. And you desperately need those abductors if you ever have to convert this fusion to a THR later on. You don't want them too stretched or too tight.
Perfect. That's the kind of strategic thinking examiners look for. Okay, we know how to do it and the position. Let's quickly cover the why. What are the main reasons someone ends up needing a fusion in the first place?
Yeah, the indications, well, they're often pretty serious situations. These days, probably the most common reason we even consider it is as a salvage procedure for a failed total hip arthroplasty. Multiple revisions, bone loss, infection.
Right, when other options have run out.
Pretty much. Beyond that, you might think about it for certain young, very physically active laborers, guys doing heavy work who have really painful arthritis or ankylosis just on one side, often after a bad infection or major trauma. Then you've got less common reasons like neuropathic arthropathy, a short code joint, and sometimes as part of a big reconstruction after taking out a tumor.
Okay. But the big downside, the trade-off, is the stress it puts everywhere else, right? I remember seeing some pretty stark data on chronic pain afterwards. What's the deal, especially with back pain?
Oh, the numbers are definitely striking. You really have to counsel patients about this up front. There was a long-term study, followed patients for like 26 up to 52 years, and 75% of them developed chronic back pain. 75%.
Wow, 3 out of 4. That's huge. So it's almost expected.
It really is, over the long haul.
Right.
And it's not immediate either. The data showed the back pain typically started, on average, about 24 years after the fusion.
24 years. So the body copes for a couple of decades, and then
the lumbar spine just gives out from the strain. And it's not just the back, it's also pain in the knee on the same side and pain in the hip and knee on the other side, all trying to compensate for that stiff hip.
And those pains, the back and the other joints, That's usually why they eventually come back asking for a conversion to a THR, right? They just can't take the compensatory pain anymore.
Exactly. That's the #1 driver. They've traded hip pain for back and knee pain, essentially, and eventually that becomes unbearable too.
Okay, let's shift gears to that conversion. Definitely not your standard primary hip replacement.
Right.
So before you even start planning the op, templating, anything, what's the absolute first non-negotiable thing you have to sort out?
The absolute first step before anything else is nail down why they had the fusion in the first place. And critically, rule out any ongoing infection. If that original fusion was done because of infection, or if you have any suspicion at all, you must plan for a 2-stage procedure. No question. That's the gatekeeper decision.
Right. Miss an underlying infection there, and the new hip is doomed from the start.
Absolutely. Catastrophic failure waiting to happen, recurrent infection, losing the implant. It's the nightmare scenario. So rule out infection first.
Okay, mandatory 2-stage if infection's even suspected. Got it. So let's say we've ruled out infection. The pain seems biomechanical. Now we're planning this complex revision. The notes mention the White House paper from JBJS in 2013. What does the detailed pre-op prep look like for this kind of major undertaking?
Prep is massive for these. First off, talk to your anesthesia colleagues. This could easily be a 4, 5, maybe even 6-hour operation. Significant blood loss potential. They need to be ready. Second, imaging. You need your standard templates, obviously, but you must get long leg films. You're going to have a leg length discrepancy, guaranteed, and you need to plan how to manage it accurately. And absolutely essential, get a CT scan. You need to see the bone stock in 3D, figure out where those old screws were, how much bone is actually there to work with.
Okay, CT's mandatory. What about in the OR itself? You mentioned needing an image intensifier and backup implants. And the stem choice, the notes, suggest an uncemented tapered stem. Why that specifically? Seems counterintuitive with potentially poor bone.
Yeah, that's a good question. Often comes up. You need the psych available, definitely, to help guide where you're reaming, especially on the acetabular side, finding that true hip center again. And backup implants are crucial. Always have dual mobility options, maybe even constrained liners on the shelf, because you just don't know what the soft tissue stability will be like until you're in there. Now, the stem, uncemented tapered. The thinking is those old screw holes, they're stress risers. If you try to ream and cement a long stem past them, you risk propagating a fracture right through those holes.
I see. So the taper aims for fixation proximal or further down, bypassing those weak spots.
Exactly. It lets you get stable fixation, usually diaphyseal, without having to disturb or rely on the bone right around those compromised areas near the old fusion site. It's a damage control strategy in a way.
Strategic, makes sense. Now, probably the single biggest factor determining success after conversion, abductor function. How do we figure out if the patient actually has working abductors left?
This is absolutely critical. If they have poor abductors, you must tell them beforehand the outcome might be suboptimal limp, instability, maybe even failure. We assess it 3 ways, really cover all bases. First, clinically. Just ask them to try and abduct their hip. Can they even initiate it? Can you feel any muscle firing when you palpate over the trochanter? Second, EMG. Electromyography. This gives you objective data on nerve function. Is the superior gluteal nerve intact and firing? And muscle response. And third, MRI. This actually lets you look at the muscles themselves, assess the bulk. Is there severe atrophy? Is it all replaced by fat? That tells you if the damage is likely irreversible.
Okay, so that triad, clinical exam, EMG for electrical function, MRI for muscle quality. That's the comprehensive answer.
Yeah.
Let's move into the OR. What's the go-to surgical approach, and what's this napkin ring osteotomy they mention?
Generally, the posterior approach is preferred, but you have to be prepared for it to be extensile. You'll encounter a lot of scarring back there. The osteotomy, the napkin ring osteotomy. It's basically how you separate the fused femur from the pelvis.
Napkin ring? Sounds quite neat. Why that specific technique?
Well, the idea is to make a controlled cut circumferentially around the base of the fused femoral head-neck region, right at the level where it joins the pelvis. You're trying to carefully peel the femur off the acetabulum, often taking a thin layer of the fused bone with the femoral side. It helps define where your eventual femoral neck cut will be, but it's tricky. Very dense bone, very scarred tissue. High-risk phase.
And the biggest risk in that posterior scar tissue? Sciatic nerve.
Absolutely. The sciatic nerve is almost always stuck down and scarred back there. You have to find it, meticulously protect it. It's probably the most nerve-wracking part of the dissection. Also, you need a plan for the greater trochanter. If it's still somewhat defined and seems to have abductors attached, you might need to do a formal trochanteric osteotomy to lift the abductors off safely. And if you do that, you got to be super careful about the superior gluteal nerve, which supplies them.
Okay, protect the sciatic, manage the trochanter. In that mess, how do you know where to actually make the new femoral neck cut? Is there a reliable landmark?
The best landmark, usually the least distorted one, is the pubofemoral arch, that bony arch between the pubis and the femur, inferiorly. Use that as your reference to gauge the level and angle for your neck cut, trying to restore the hip's natural center of rotation.
Pubofemoral arch, got it.
Yeah,
And once you've prepped the acetabulum, implant choice.
once the socket's ready. Well, if you have any doubts at all about the soft tissue quality, the tension, the stability, don't hesitate. Use a dual mobility implant or even a constrained liner. The risk of dislocation after these conversions is high, so build in that extra stability.
Makes sense. And postoperatively, what are the key restrictions for the patient?
Given everything you've likely done to the abductors, maybe mobilize them, maybe reattach the trochanter. The main thing is no active abduction for 6 weeks. Strict avoidance. Let everything heal.
6 weeks, no active abduction.
Yeah.
Okay, that covers the modern approach pretty well. Just quickly to round things out, the notes mentioned a historical procedure, iliofemoral arthrodesis. Sounds complex. Can you just briefly describe how that worked?
Sure. It was a type of extra-articular fusion. Basically, the surgeon would raise a big flap of bone from the outer side of the ilium, the pelvic wing. The trick was they kept the bottom edge of this bone flap still attached to the ilium that was the hinge, the blood supply. Then they'd swing the top, free end of the flap down, and slot it into the greater trochanter. So you're essentially creating a bony bridge from the ilium to the femur outside the joint itself, hoping that would fuse solid.
Well, okay. Sort of grafting the pelvis onto the femur. Definitely highlights how far things have come.
It certainly gives you perspective on the challenges they faced.
Right. Okay, let's wrap up with the key takeaways for you listening. When you're revising hip fusion and conversion, remember that fusion position, 20 to 25 degrees flexion, neutral, everything else. Know the 3 ways to assess abductors: clinical, EMG, MRI, and absolutely nail the pre-op infection rule-out, 2-stage if there's any doubt. Be ready to explain why conversion needs that CT, the long leg films, the backup implants, all drawn from resources like the OrthoMade's simple notes on mokyingren.sg.
Yeah, it's tough material, no doubt. But really focusing on the strategy behind each step. That's what takes you from just knowing facts to having real surgical judgment. Keep up the hard work. The effort you put in now really does build the foundation. And as you go about your studies and your work, maybe keep this thought in mind. It's from Proverbs chapter 12, verse 5. The thoughts of the righteous are just. The counsels of the wicked are deceitful. May you stay diligent, stay focused, and always strive for what's right and wise in caring for your patients.